Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 459 of our pharmacotherapy series, which majors in pediatric malignancies. This video discusses the case of patient JOB who was discussed in part 458 of this pharmacotherapy series. What are the various treatments available for CNS preventive therapy? What factors determine which treatment is selected for JOB? All treatment protocols for childhood acute lymphocytic leukemia use some form of CNS preventive therapy, although different regimens are used. The first successful CNS prophylaxis treatments were 2,400 CGY of craniospinal radiation with or without intrathecal methotrexate, which markedly reduced the CNS relapse rate. However, the adverse effects of cranial irradiation were problematic. These included decreased intellectual function, dysfunctions of the neuroendocrine system, and poorer psychosocial functioning. As a result, clinicians sought alternative, potentially safer forms of CNS preventive therapy. For example, lower doses, 1,800 CGY, of cranial irradiation were combined with intrathecal methotrexate to reduce the CNS effects, which proved to be equivalent to 2,400 CGY in preventing CNS relapse. Nevertheless, because concerns regarding the long-term toxicity of cranial radiation remain, especially for younger children, it is currently reserved for patients with detectable CNS disease on presentation, some patients with T-cell acute lymphocytic leukemia, and patients with CNS relapse. Currently, CNS preventive therapy includes intrathecal methotrexate alone, triple intrathecal chemotherapy, methotrexate, cytarabine, and hydrocortisone, or intrathecal methotrexate combined with systemic dose intensified methotrexate. Because patients differ in their risk for developing CNS leukemia, CNS preventive therapy should be tailored accordingly. Children with standard acute lymphocytic leukemia have equivalent CNS protection rates with either cranial radiation or intrathecal chemotherapy, as long as adequate intensive systemic therapy is provided. These patients are treated with triple intrathecal chemotherapy or intrathecal methotrexate, depending on the institutional protocol. The next question reads, what are the chronic adverse effects of intrathecal chemotherapy? The chronic toxicities of intrathecal chemotherapy are now being determined. When examined for effects on growth, Triple intrathecal chemotherapy demonstrated no effect on the final height achieved by children, in contrast to a reduced final height in patients receiving cranial irradiation. Limited evidence suggests that intrathecal chemotherapy may be associated with some neuropsychologic deficits. At least one study of patients receiving intrathecal chemotherapy without cranial irradiation has demonstrated deficits in higher-order cognitive function tasks and learning disabilities in mathematics. Another study has demonstrated that children who were treated with intrathecal chemotherapy before age 5 years had deficits in the cerebellar frontal brain subsystem and in neuropsychologic performance. It is unclear whether these deficits translate into significant long-term consequences. JOB is at a low risk for CNS relapse, and the decision is made to treat him with intrathecal methotrexate. So my question to you reads: what dose of intrathecal methotrexate should JOB receive? High chemotherapy concentrations can be attained within the CSF, with relatively low doses, because the CSF volume of distribution is small in contrast to the peripheral plasma volume, 140 versus 3,500 milliliters. Drug exposure is also maximized by the longer half-life of most drugs in the CSF. The approach used for intrathecal dosing differs from systemic administration, the latter of which is based on body weight or body surface area. CSF methotrexate concentrations appear to correlate better with patient age than size. The CSF volume in children approaches that of an adult by the age of 3 years. Because CSF volume does not correlate with body surface area, intrathecal doses based on body size result in subtherapeutic concentrations in young children and potentially toxic concentrations in older children and adults. The age-based dosing regimens are less neurotoxic and are associated with a lower rate of CNS relapse than doses based on size. Using this dosing regimen, JOB's dose of intrathecal methotrexate should be 12 mg. If triple intrathecal therapy were used, the doses of intrathecal cytarabine and hydrocortisone would be 24 and 12 mg, respectively. These latter doses are also based on age, but no literature exists to support how they were derived. Nevertheless, empiric evidence supports their efficacy. JOB's intrathecal methotrexate is to be administered on the same day as his vincristine dose. So my next question to you reads: are there any special precautions that should be taken when these medications are administered in close proximity? Inadvertent administration of vincristine into the intrathecal space is almost uniformly fatal, although there is at least one report of a patient in whom death, but not serious sequelae, was prevented. Despite widespread educational efforts in hospitals and clinics, and numerous precautionary measures, deaths from the inadvertent intrathecal administration of vincristine still occur. The clinical course in patients mistakenly given intrathecal vincristine has typically progressed from backache and headache on day 1, muscle weakness, which is generalized, on day 2, apnea on day 5, loss of evidence of electroencephalographic activity by days 7 to 9, and death on day 12. To avoid the tragedy of intrathecal vincristine administration, vincristine should be admixed separately or at a different time from intrathecal medications, specially labeled and mixed as a small volume parenteral, i.e., mini bag, rather than in a syringe, and preferably delivered to the patient area for IV infusion after the administration of intrathecal medications. An analysis of the chromosomes from JOB's bone marrow reveals the TELAML1 translocation and a DNA index of 1. His minimal residual disease findings reveal the following. Blood on day 8 is less than 1% of cells, and bone marrow on day 29 shows 0.15% of cells. Based on his day 29, end of induction, bone marrow positive minimal residual disease finding, JOB is scheduled to receive a more aggressive post-induction chemotherapy regimen. This treatment is chosen because minimal residual disease findings are more predictive of the chance for relapse than are his cytogenetics. Although JOB had bone marrow minimal residual disease performed at day 8 and at the completion of induction treatment on day 29 that both indicated a complete morphologic remission, his minimal residual disease findings at the end of induction take precedence in defining his further therapy. After completion of the induction phase, JOB was scheduled to receive an intensified phase of post-induction chemotherapy known as augmented interim maintenance. My next question to you reads: what is the purpose of post-induction treatment, and what are some examples of effective regimens for this phase of treatment? Post-induction chemotherapy consists of a variety of combinations of different agents typically given on a 2 to 6 week treatment cycle. These different phases of post-induction therapy are known as consolidation, interim maintenance, and delayed intensification. Post-induction treatment has proven to be an important strategy for the prevention of relapse in children with acute lymphocytic leukemia and has helped produce event-free survival of greater than 80% in low-risk childhood acute lymphocytic leukemia. To date, the optimum post-induction regimens have yet to be determined. However, a few interesting findings from investigations of consolidation therapy are briefly mentioned. A comparison between high-dose methotrexate 5 grams per meter squared IV every 2 weeks for 4 doses and escalating, Capezi, dose methotrexate, every 10 days, increase by 50 mg per meter squared until toxicity is seen, showed improved 5-year event-free survival, abbreviated as EFS, 82 ± 3.5% versus 75.4 ± 3.6% with a p-value equal to 0.006, and no increased toxicity. In fact, there was a lower incidence of febrile neutropenia in the high-dose methotrexate group compared to the escalating dose group, 5.2% versus 8.2% respectively, with a p-value equal to 0.005. This advantage was shown in high-risk patients and is currently being studied in standard-risk patients to evaluate if there is a survival advantage in that group as well. Another trial comparing either longer duration or more intensive post-induction regimens for children with high-risk acute lymphocytic leukemia found that a higher intensity treatment regimen improved outcome, whereas the longer duration regimen did not. In this study, the higher intensity post-induction treatment was made up of greater use of PEG asparagine, vincristine, and escalating dose methotrexate. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 460.